Very good evening to all of you. I welcome you all to the Facebook Live challenge on the Surgeon-anesthetist Society task group. We have started this series since last 3 months and hope all of you are enjoying it. Today we have two presenters. First is by Dr. Meenal Chauhan and second is by Dr. Surjit Giri. Meenal is freelance anesthetist and she is very good singer also. Uh, she is going to talk about challenges of a young freelance anesthetist in the beginning of practice. So I hand over to Meenal for her presentation. Please.
Right. Thank you, sir. Thank you so much. First and foremost, a very good evening to everybody and a big thank you to the task coordinators for giving me a platform to voice my opinion on, I think, a very colossally interesting and a diverse topic, and a topic which is relevant across the globe. So am I audible? Am I properly audible, sir? Right.
Yes, right. Please go ahead.
So before I begin, I would like to give a brief introduction that why have I chosen this topic today. So basically, I passed out in the year 2014, and for the next 6 years, the last 6 years, I've changed about 3 cities because of my husband, who happens to be working with the defense. I've worked in corporate sector, medical college, both government as well as private, in secondary level hospitals, district level hospitals, that is, and I've done freelancing. Now, where the basic fabric of our profession happens to be skill across every place, freelancing requires much greater skills than our basic knowledge about our subject. That is why I thought it was important for me to share this particular topic with all of you. Before I begin, I would like to say I have no conflict of interest, no disclosures, and no advertisements whatsoever. So Kristen Butler, who happens to be the American softball coach, once said, "Be thankful for every new challenge because each will give you more strength, wisdom, and character." When I was going through my, wanted to make my presentation, I was curious to know the definition of a young working professional. Now, Wikipedia states it as anyone who's in their 20s or 30s in a white-collar job. But the Young Working Group of Ontario says that any individual who can adapt to change, is innovative, and has a clear vision for their community is a young working professional. So that means age is just a number. And I have specifically put this slide here to tell you all that this particular presentation is not only for beginners or for PGs or for those who are, wanting to create a niche. It's also for all the people who are practicing for years together. This will give you food for thought. This will also help you to realize maybe you're also making mistakes, and this will help all the others to become better. As Alvin Toffler, who is the father of modern digital revolution, said, the illiterate of the 21st century will not be those who can't read and write, but they are those who can't learn, unlearn, and relearn. So learning is a continuous process. So where most professionals have a slow beginning and a steep acceleration, and later the plateau is reached, we in the medical community have an avid proficiency phase. This is really important for us because we have a late blooming curve. That is because of the vast variety of patients we are seeing. Our course is so vast. We are practicing across the globe in different kinds of situations. And proficiency is all the more important in our community because we are dealing with human lives. So you can understand how important it is. Being proficient helps us to change our deliberation, plan, and assessment as the situation changes. And sometimes it also helps us to deviate from the normal, which you can see presently in the COVID times, So there are so many inventions, and I think they should thank the medical fraternity, for being the beacon of light across the globe. There are intubation boxes, face shields, screens, COVID consent forms, and so much and so forth, which has been developed by the anesthesiologists. So now, who is a freelancer? A freelancer is somebody who is self-employed, is not working under anybody. But of course, we have nexus, kind of the people, want to work with only certain people, and the freshers might not get a breakthrough. But then that's real small number. Initially, freelancers are clueless. We don't really know how to begin, how to, reach the system, who to talk to. Slowly, as you start getting a grip on things which are happening around you, there happens a case, it can be a situation, it can be a person who discourages you maybe, and then only slowly mastery activity is achieved. Therefore, I firmly believe that freelancing is much far difficult than working in corporates or medical colleges where you have an umbrella above you. Now, coming to the various challenges which we face as freelancers. When you do your residencies, we are doing it in big medical colleges which have fully air-conditioned OTs. There are workstations, multi-para monitors, respiratory gas monitors, central oxygen pipeline supplies, and a fully loaded airway cart. But when you begin your practice, you end up working in a low resource setting. Now, this definition has been given in Anaesthesiologist 2018 issue. It is a high impact factor journal. It states that a low resource setting functions on lack of funds for procurement of drugs, equipments, instruments, and manpower. And there is insufficient infrastructure in these places. Therefore, I've divided my challenges into 4 main headings. The first being resource-centric challenge. You can see this is the most basic boils which you find everywhere. See, here you still see a isoflurane vaporizer, but most of the time they don't even have this. There's just a Coleman's vaporizer. Many people are putting isoflurane and sevoflurane into that only, and they are using it. Now, I don't know how does that work because the calibration is totally different. But then, wo doobte ko tinke ka sahara type of thing is there, and people are doing this. Even the cylinders, they might show, the gauge shows it is full, the pressure gauge shows it is full, but somewhere midway, the oxygen suddenly finishes, the nitrous finishes. There is not even multi-para monitors present in a lot of places. Forget about respiratory gas monitoring. A lot of my senior colleagues I know who are doing laparoscopic cases without ETCO2 cables also. Now, whether it is being done under spinal or it's being done under GA is again a debatable issue and itself another topic of discussion. Airway adjuncts like LMAs and bougies are also not present. Forget about a video laryngoscope. And even essential drugs like noradrenaline is absent. So this happened with me when I visited a particular nursing home before starting the case. I was just checking on the emergency drug list and I asked them, there was none of these emergency drugs present. So when I told them, they said that, Madam, kuch hoga to niche hi to medical shop hai, wahan se le aayenge. So, that's the level of ignorance which still at a lot of places people have. Though the PPF forum is trying their level best to make the rules and the regulations, but I don't know, in a lot of places they are still not being followed. This is a typical OT. This is still a very well-lit OT. It's big, it's huge, but most other OTs are small. You can see a defibrillator here, but you don't have defibrillator in a lot of places. The OT table is mostly like this. It's going to be manually operated. So if you want to do a head up, a head low, all that is your headache. You might get a technician to help you. You might not get a technician to help you. Now, this slide I've specifically put to point out, just look at the paraphernalia of the surgeon. There is a C-arm present for the orthopedician. There is a striker trolley or some kind of a great trolley which is present for the surgeon. But look at our boils. It's again the most basic version of boils without any central oxygen supplies again. Okay. So these places have no trained technicians. There's lack of adequate manpower in case if there is an emergency. There are no post-anesthesia care units and there is no ICU or ventilator. There might be a transport ventilator which might be present, but mostly nothing else is present. Now we have to understand that most of these low resource settings are being run by surgeons, who have real scant regard for our specialty on the whole. And not everybody might be like that, but I think 90% of the surgeons are like that. So where cost efficiency ratio starts playing a great deal. For example, I was told once that why are you using fentanyl when you can actually get away with Fortwin? So even if you want to try something new, sometimes you're stopped in certain institutes, in certain places, and the kind of mindset. Also the pre, intra, and the post-operative, safety of the patient or the anesthetist is of little concern for all these places. So we have to become the jack of all trades, from dealing in the patient to putting the IV line to probably, loading the drugs to sometimes even running around giving Vicryls to the surgeon and dealing the patient out. Sometimes we have to be the jack of all trades. Also, these places have no fixed protocols. You have to remember that all of these places have multiple anesthesiologists visiting them. So somebody might want to give 3 oxytocin ampules, somebody might want to give 4. Somebody says, I want to load the drug. Somebody says, no, you load the drugs and keep. Okay, somebody might use a dopamine if there's a shot, and somebody might want to use a noradrenaline. So everything is very different. Even the staff gets confused, and the staff is also not permanent. Now, for me, I think the most important and defining criteria is there is no additional help from a trained anesthesiologist if there happens to be a critical incident which you face. Another thing which I was going through, I realized that there's lack of any database in our country. Being a developing country, certain corporate hospitals do have these systems of database, but on large, we don't know where to take the database from. So we have to completely depend on the patient party. So if there has been a past airway crisis, we don't know if they don't tell us. But this is very unlike an Epic Data software which is present in USA, where everything is there. I think that is, my US colleagues can tell me better, but that's whatever I read, this is what they showed. The next challenge we face is a patient-centric challenge. So most of the times we are being called on the day of surgeries in these particular places, especially daycare surgeries, when the patient has already been wheeled in and there are partially investigated cases or uninvestigated cases, but we are supposed to be giving anesthesia. And sometimes we are told, "Arey, short GA hai." I mean, I don't know what the short GA really means. So who do we really blame? Of course, I know it's the surgeon, but I think a great deal of it is also us anesthesiologists. Why don't we do PHCs? Why don't we demand that we want to do PHCs at least 1 hour before if it's a daycare procedure? A lot of times we are hopping from one nursing home to the other. We want to save even 15 minutes so that not even 1,000 rupees of us goes wasted. That is the mentality mostly. But PHC clinics have come in a big way in many cities like Nagpur, Nasik, and they are doing very well. And why not? It helps us to create some extra money also if you charge 300 or something. I have done a few PACs like that which were high risk and I have charged them. Now this is a very important thing which I would like to tell you people. Now consent. See, you have to remember that when you're working in corporate sector or when you're working in medical colleges, you might have a consultant or you might have somebody else. You have a team of people. Okay, but here you are wholly and solely responsible for every little action you take. Anything you have spoken, a drug you have given, a decision you have taken. Therefore, consent taking also should be done by us and not by any of the OT staff or not by the surgeon. Let the surgeon take the surgeon's consent, but we should take the anesthesiologist's consent. We must explain to the patient and the patient party, especially if it's a high-risk case, say 3-4 patients. Okay, if there are complications, if there's an on-table death possibility. So it's important to take this consent. And do not depend on the surgeon. Sometimes the surgeon happens to be a friend, or sometimes, we are so new, we have just entered this particular field of freelancing. A very senior surgeon might just intimidate you and tell you, "Arey, ho gaya, maine baat kar li hai, rehne do." And that's happened with me also many a times. But hold your ground. Don't get panicky. Just do what you have, what you set your eyes on. Next is documentation. Yes, very important where it is required. So if, suppose, for example, you're giving spinal anesthesia to, say, a polio patient, do document the disabilities. Or suppose you're taking a PIH patient intraoperatively, and who was previously maybe having high BP, do record the preoperative BP, or if there is the urine output, that there are no impending signs of eclampsia, and then take the patient. Next, which has saved me a lot of times, is WHO surgical safety checklist. And also the WHO anesthesia safety checklist, which I'll also talk about. Now, this particular safety checklist has a lot of parameters, which should be actually read by the sister who is there, and a timeout should be performed. So I have attached, these are whatever I'm telling you, I'm practicing this, and that's why I'm telling all of this to you. For example, sight is a very important thing. You have to understand that in the medical court of law, even we are held responsible if the orthopedician operates on a wrong site. So this is also one of the things which you can include when you're beginning your freelancing practice, or in fact even later. Next is the anesthesia safety checklist. So this I will give you an example how this particular thing saved me. So there was this 1.5-year-old child who was supposed to be taken for congenital hernia surgery. This happened about just 2 months back with me. And previous day I went, I did the entire PAC, explained everything to the patient party. Next day, I see the patient wheel the baby inside, put the intracath, he's howling, screaming, and then suddenly this anesthesia safety checklist happens to flash in front of my eyes. And I read, has the patient had no food or drink? Oh God, I did not ask this to the family, at that particular time. So I run out, I ask them, and they tell me, as usual, the normal scenario, बहुत रो रहा था, आधे घंटे पहले माँ ने दूध पिला दिया. So I think a big catastrophe was saved that day. So this is how these are little things which can help you improve your practice, make you, fine tune yourself. And even if you have to keep running in 10 different institutes, at least you have your entire documentation in front of you ready. Third challenge is the surgeon-centric challenge. Now, I mentioned this earlier also, that you have to understand and accept that most surgeons are less empathic towards the anesthesiologist. Now, I say most surgeons and not all the surgeons, okay? And, we have to take the first step. You're supposed to melt the ice. You should go and do the talking. Not only talk to the anesthesiologist present in your area, but also the surgeons. Introduce yourself. Networking helps. It's important. But networking helps only as long as you want to get your job. When you want to sustain your job, it is your skill, it's your courage, and a lot of other things which happen in freelancing. Sometimes you'll get too little work, but at times when maybe, your seniors are out of station, they are not present there, you might, get a lot of work also. Now, this is my limited experience out of which I'm talking. I think it's okay to work with a surgeon who is probably a little time-taking, or I would say a little less skilled, rather than working with somebody who's very intrusive, who's trying to dictate the type of anesthesia which you should give. कि अरे GA क्यों दे रहे हो, spinal में करा दो laparoscopy, or who is forceful towards you taking uninvestigated cases, who's trying to overpower and cloud your judgment. See, all this ultimately leads to trust issues and nothing but a big professional hazard. We have to understand that when we are venturing out into freelancing, sometimes, we are scared of these stalwarts. They are the stalwarts in their fields, and maybe they are really good and they have a very good hand. And we are scared to kind of argue with them or to cut them short. And hum log bahut baar we just give in to their demands. And that is the beginning of all the problems in freelancing practice. Another problem is that of remuneration. The RVG, Relative Value Guide, which has been created by the PPF Forum, I don't think it's being followed in a lot of places. It's being followed in very, very few places. I think Dr. Surajit Giri, who's the next speaker, he is doing it beautifully. Dr. Pranav has been doing it, and a few other places, but I couldn't start it also. Sometimes you're being paid too less, or sometimes all your money is stuck and you're paid after a while. The last and the most important problem I feel is anesthesiologist related problem. So, when you begin your practice, sometimes your own colleagues start depreciating you. Now, you can call it insecurity, greed, competition. But all this back slander, ill talks leads to lots of dignity and respect in the eyes of each other. Our own community loses respect. Also, there are certain anesthesiologists who are resorting to surgeon-pleasing tactics. For example, you say, I want to do a PAC, but the other says, I really a PAC ka kya zarurat hai? Or you say, this is my rate, I will not do a DNE in less than 1500. But somebody else is ready to do it even in 800 rupees. So this is surgeon-pleasing tactics. The other set of anesthesiologists who are present are overconfident. They feel they are invincible. They feel they own that nursing home. They feel that, when they go, the doctor is going to shut down the entire work and no other person can come in their territory. They are the alpha males. That's the way they behave. So they try to misguide. A lot of them try to misguide. They try to intimidate. Again, we have to be a little careful. So why I'm saying all this, I'll also tell you the solutions to all this later. So all these various challenges, be it resource, patients, surgeons, fellow anesthetists, they all sometimes make even breaking into freelancing or sometimes even continuing freelancing a little demoralizing for a few people, if not all. So we've spoken a lot about the challenges, but what exactly is a challenge? I see it as an opportunity to expand and grow, but that's possible only if you have a growth mindset. Where your attitude determines everything, where you feel inspired and you want to learn and persevere and become better. And why not? Why not use these challenges as opportunities to make yourself more firm in this field of freelancing and contribute in a much better way? And I'll tell you how. So there are 6, 7, 8 points which you can follow and probably help enhance your practice and skills. First being, keep yourself updated. Do attend one conference or one CME a year at least. Do read half an hour a day about any difficult case which you're about to do maybe the next day. Okay, and learn a new skill every year. It can be a new area adjunct use, it can be a block. Whatever you know, keep practicing and strengthening your techniques. Suppose you practice caudal block very well, so please give it, don't stop doing it. Therefore, expand your horizons. Next is break your comfort zone. When you go and meet people, when you go and meet these stalwarts who are giving lectures, interact with them. No question is a silly question. You must come out with every little doubt you have because they were also in your shoes once they started out. So learn from their life experiences. Therefore, do not have complexes. This is a very important thing which I would like to say and which I think task group is doing beautifully. Please share as much knowledge as possible. And we know, it's all knowledge ka bhandar hai, but you have to also choose the correct kind of knowledge. Don't hold back. The more you share, the more you argue and the more you debate, you might fail initially, but then after all this collaboration, this learning pit, when you fall into this learning pit, you will come out much stronger. So be a visionary. Like here, I would like to thank Hetal sir because he keeps posting such amazing videos on YouTube. I mean, I've also not seen all of them, but then whatever little I know about blogs is because of a few people I keep following, and he's one of them. Next is be flexible. Please practice different kinds of techniques. You might want to use only a thiopentone, but there is no harm if you also try to learn from your junior how to use a propofol. And if in case you get stuck, please call for help. Do not try to be, magnanimous by saying that, I can do this and that, when actually that's low resource setting might not be able to hold on to your techniques. Because if plan A doesn't work, there are many other plans. So kill your ego. I think this is the most important slide of this entire presentation. Please stand for yourself. We as anesthesiologists, we really bend down in front of the surgeons. But I don't know what is the requirement. If you want to do a PAC, do it. If you demand a particular remuneration, let's have that. If you want to put an 18-gauge cannula for a cesarean section, then just do it. If you want to use a fentanyl, please do it. Why can't we be stern but humble in our approach? So don't sacrifice on your ethics. If you've learned something, you might have to bend the rules here and there a little bit, but not so much that it compromises on the life of the patient. So be stubborn and be brave about being stubborn. Communication, of course, wherever you're practicing, please keep good contacts with your fellow anesthesiologists. If you're continuously backslandering, talking ill, and all this is happening, it never creates a good environment. Remember one thing, they require you as much as you require them. There is no anesthesiologist who can be overconfident anytime. Today you're overconfident, tomorrow you'll end up failing in your intubation, failing in your block, failing in putting an IV line, failing in whatever your central line, something or the other will fail. So God is a great leveler. Life is a great leveler. So solve all your differences amicably. In fact, group practice has come out in a very big way in the practice of freelancing. Now, this is especially for all those who want to begin with their practice, just, who are about to start. I would like to say, keep a bag of all the essential drugs and instruments ready. So I have my own peripheral nerve stimulator, laryngoscope, LMAs, which are not present in a lot of places, bougie, and reach early, plan the case, check everything yourself, at least for the first few months till you're comfortable and letting the technicians take over. Another advice I would like to give, before you venture out into freelancing, if you've just finished with your PG, try to work in a fully loaded institute, an institute, in which you get exposed to all kinds of cases, where you might also need to work with really lesser infrastructure. So be smart and work safely before venturing out and taking the entire blame on yourself when you're doing freelancing. This has been covered beautifully by Dr. Sai. You have to be sure about your professional indemnity, because once you lose a case or once you have a death on table or something like that happens, it's not only your reputation, your confidence, your money, but your entire life, goes in rectifying and getting the money back or paying the party and stuff like that. All this happens. So please uh, have one professional indemnity. Lastly, please have patience if you're venturing out into this, because nobody is going to make place for you. You have to make your own space. You have to go and sit there and be patient first with yourself, and that's possible only if you begin to live in the now moment. If you realize that practicing mindfulness is everything, you have to do deep breathing exercises, meditation, because you're permanently surrounded by stress not only by the doctors, by the surgeons, by the doctors, by the patients, by the technicians, even the everything is a stressful environment in freelancing. So you have to keep meditating, keep yourself calm, cool, and then set out for all your things. So at the end, I would like to say, जिनमें अकेले चलने का हौसला होता है, उनके पीछे एक दिन काफिला होता है. Now, freelancing is a really lonely journey, and it is. But take the journey, even if it means all alone. Because ultimately, we are our own best friends, and we have come alone in this world to fight our own journeys and write our own destinations. Thank you so much. Thank you, Dr. Hetal. I'm done with my presentation.
Thank you very much, Meenal. It was an excellent presentation. And I will say everybody must salute Meenal, because her husband is an army man, her kid is small kid, and she is doing freelancing practice with all. So very nice presentation, and hats off to you, Meenal. Thank you very much for beautiful presentation.
Thank you, sir.
Can you stop?
Yes, sir. I'll stop sharing.
Can you stop sharing your screen, please? Thank you, Meenal. So next presentation in Sujit, you can share your screen. So next presentation is by Dr. Surjit Giri. I don't think he requires any introduction. He is the boss of Assam. He is from Sivsagar. He is working. He is working as a freelancer. He works in ICU and he works everywhere. He is secretary of Assam branch of IS. He is doing lots of work about awareness about anesthesia, and all of us know that how effectively he is doing this